Hi, everyone. Um, Welcome to the UVA Medical Center Hour and the annual Bice Memorial Lecture. My name is Margaret Hayden. I'm a primary care doctor here at UVA and faculty at the UVA Center for Health, Humanities, and Ethics, which runs the Medical Center Hour series. Today, we are very happy to be partnering with the School of Nursing to put on this great event. I have just a very couple quick logistical details to cover at the beginning. One is due to the weather. Today's session is Zoom only, so thank you for logging on. There will be some time for question and answer after the talk. The way we'll do it is there's a Q&A tab at the bottom of your webinar. You can use that to enter your questions sort of throughout the talk. I'll be monitoring them, and at the end of the session, we'll have some Q&A back and forth with our speaker. And then for those of you who are looking for any continuing education credit from today's lecture, hopefully you've seen the circulating slides. The key code you'll need for today is 29826, and we'll have those slides circulating at the very end as well. If you have any questions or issues with the CME process, you can reach out to Charlene Kaufman. You have about a week after the event to claim your credit. That's all for me for now. I'm delighted to turn things over to the School of Nursing, Dean Bernholt, to introduce our speaker today.
Thank you, Margaret, and thank you for having us all. I am really pleased to welcome you to the annual Bice lecture. I hope everything is safe in this weather, and I'm glad we converted to Zoom only so that you can continue to be safe. So let me tell you a little bit about the Bice lecture and also about our speaker. So the Bice lecture is named for alumni, Navy nurse, and former dean of UVA School of Nursing, Zula May Baber Bice. She led the school from 1961 to 1962, and again from 1964 to 1966. Today's speaker, Dr. Lauryn Walker, is a nurse leader and recently appointed Deputy Secretary, Health and Human Resources for Virginia. So recent that she just told me she's still looking to figure out how to get to her office. She has a strong focus on health policy, Medicaid innovation, and population health leadership. Before she was appointed to the Deputy Secretary of Health and Human Resources position, she held the position of Chief Strategy Officer and Research Consortium Executive Director for the Virginia Center for Health Innovation. In these dual roles, she led the Virginia Task Force on Primary Care's economic policy work, and she also advanced multi-payer initiatives and cultivated partnerships across Medicaid stakeholders to address critical statewide priorities. In addition to her newly government leadership, she is president of the board of Richmond Aging and Engaging, a community-based organization focused on reducing social isolation among low-income older adults in Virginia. Lauryn is a registered nurse and a member of the Virginia Medical Reserve Corps. She earned both her BSN from Hopkins, a Master of Public Policy also from Hopkins, and her PhD in Healthcare Policy and Research from the School of Medicine at Virginia Commonwealth University. That's where I met her. As a matter of fact, I was pleased to serve on her dissertation committee and have followed her since in her career across 2 states. Please help me welcome Dr. Lauryn Walker as she presents Beyond Band-Aids and Duct Tape, Building Systems That Care. Welcome, Lauryn.
Thank you so much, Dr. Bernholt. That was a very kind introduction. I'm very much honored to be here today with you all. Unfortunately, it's virtual. I would have really loved to have seen you all in person, but glad that we were able to make sure that this actually got on today. So thank you also to the whole team at UVA for helping with all of the logistics of this. It's a huge honor to be able to be here with you all today. So I am going to share my screen, some slides here to go ahead and start presenting. Bear with me as I work through the technical pieces of this. I have a new laptop so with my new role, so all things are a little new for me right now. So before I start with the actual talk, I just want to give the full disclosure here that I am not here on behalf of the governor today or the administration. All the views that I will be speaking about today are my own. And so I just want to have that disclosure up front that this is today for me to be talking with you all about, my own views on healthcare and the system here. And I really do want to spend a little bit of time talking with you all about the systems that we're surrounded by every day. We have a system that probably none of us would have set up this way if we could do it from scratch. You all are in care and the chaos of patient care every day. And so we're going to spend the next hour or so talking a little bit, raising our heads up from that chaos and really talking about the system that's surrounding us. So I wanted to begin by really kind of level setting us in what our system really looks like. So we have a pretty fractured system here. We have health insurance that varies, and we have providers that vary. And there are so many different ways in which our health system is fractured that, I could go on and on about this, but I wanted to at least just level set on one component of this. So this is going to give you a sense of what Virginia looks like here. So we have about 6 different insurance types. Broad insurance types in Virginia. About half of the population in Virginia is on some sort of commercial plan or an employer-sponsored plan. And the other half is fractured among 5 different types of plans or uninsured. So about 7% of Virginia is uninsured right now. When we look at that, that doesn't necessarily mean that everybody can go to the same places. So you'll see there on the right, the providers. This is just an example looking at primary care providers in Virginia, but you'll see that there's a Venn diagram of who takes what, and it's very confusing. So maybe about 12% only take commercial plans. So that would just be that other blue side on that employer sponsored. But just because they take one commercial doesn't mean they take all the commercial. And so there's really a mismatch of trying to figure out what insurance you have, who can you go to? What does that mean? Is everybody taking the same thing? And it just leads to a lot of confusion. To add to that, you see my beautiful drawing over here the little red hash marks over here. Coming from the public policy perspective here, when I look at, okay, how do I improve this? How do I start reducing the fractures? At the state level, state can regulate about 1/3 of what you see on that left insurance side. And so that's what that red hash mark is over there. They can regulate fairly well Medicaid, although it's a public-private partnership there. Or sorry, it's a federal state public-private partnership there. And then you also have the marketplace, which in Virginia, we have a state-based exchange. And so there's a fair amount of state-based regulation there. And then about 1/3 of the commercial market in Virginia can be regulated by the state. The other 2/3 are really federally regulated. So when you're looking at how do we drive change, how do we drive alignment, how do we make sure that our systems are working together, it's really difficult because even when you're trying to, with the best of intentions, have your own regulation to try to improve things, you're actually adding to the fractures because you're really only able to drive change in about 1/3 of that population at the state or 2/3 at the federal level. And so there really is a huge issue with fracturing. And so what does that look like for a patient? So on the patient side, you have fractures because you're trying to figure out what provider you can go to. You have provider directories that are wrong because it's really unclear whose job it is to update them. It's really unclear who actually takes your health plan. I work regularly with both providers and health plans, and I can tell you that I'm often in conversations in the room where they do not agree whether or not somebody is in network with that health plan. It's very confusing, and people have a hard time figuring out what exact health plan somebody takes. It's unclear as a patient when you walk into the door what care you need and how much it will cost. If somebody even told you the cost, would you then be able to make a decision about whether or not it was worth it or not? It's really difficult to know what kind of care is actually necessary or beneficial. you can't really tell where the system is breaking down when you have a problem. So for instance, if you are a patient, and this happens to me all the time, and I'm sure it happens to you all too, you walk into the pharmacy, you try to pick up your prescription, they're telling you you need a renewal of your prescription or a renewal of your prior auth, and then you have a back and forth. Well, is the breakdown at the pharmacist? Is it at the doctor's office? Is it at the insurance company? There's so many steps along the line that when you're trying to fix a problem, it's hard to know who to go to fix it as a patient. You have providers that don't have the time or skills to help. You may be walking into one provider with an issue, and they may not be the ones that actually are able to help you. And it's really hard to know where the right entry point is. We have a primary care system, but that also may mean that you're walking into a provider that's referring you to another provider. It can be a long change and confusing. And then there are long wait times everywhere for every type of specialty. And we can go into some of the actual data on that, but they're getting longer and longer. So on the other side of this is the clinician side. We have a fractured system for our patients, and we have a fractured system for our clinicians. Okay, so looking now at how the system's fractured for clinicians. So we have a lot of patients, and there's never enough time, and there's never enough resources. And I think we all feel that every single day. That is one of the main constraints that makes our jobs really, really hard. The second part here is that when we look at how we're paid and how we're assessed, it often doesn't match up with whether or not we think somebody is a quality clinician or not. And that can be a real struggle. Our own career ladder is really limited, and our achievements don't necessarily fit with the reward system. I know we often, for instance, at least on the nursing side, you'll see, for instance, a very high quality bedside nurse may get promoted because she's excellent and get promoted into like a nurse management role, and maybe isn't the best manager, but was a fantastic bedside nurse. And so we have a mismatch of where our expertise is fitting with our skill set to try to be able to have a career ladder that helps people feel like they're achieving and get to move up and develop professionally, while also making sure that the skill sets really match the job. And I'm sure that never happens at UVA, but it definitely happens elsewhere. Burdensome documentation, not sure how to navigate a care coordination. Oftentimes, especially on the nursing side, our job is to be a care coordinator, but we're not necessarily trained in care coordination. And so we tend to do the best that we can and navigate a system. I will say, and I say this regularly, I have a PhD in health policy. I am a nurse, and yet I cannot navigate my own healthcare. It is incredibly challenging to do. And then the last part here is it really depends on where you're working, on what your experience is. And that can also be a huge challenge because it's hard to make, large systemic changes when the experience is varies so widely based on the setting that you're in. And really, I think all of this together would say we are really asked to hold healthcare together with these Band-Aids and duct tape to try to be fixing all of these different fractures. And we come in as clinicians with a goal to be trying to insert humanity and heart into the system every day. And it's not a system that's designed to do that. It's a system that at its core is fractured. And so our role is really to try to figure out how do we start looking at systemic changes to try to make sure that we don't fail in the humanity side of this. And we know that we are sometimes, no matter how much we as humans care. And I'm going to talk a little bit today about some of my own personal experiences that I don't usually talk about in these kind of professional types of talks, because I really want today's conversation to be about the humanity side. And I think that starts with us as clinicians being people. So I'm going to talk a little bit today about my own experiences with being both a provider and being a patient. I'm going to start a little bit talking about the clinician side of this, because I think the clinician side is where you all are sitting every single day. So when I was a critical care nurse, and I was a pretty experienced critical care nurse, I was up in Baltimore And I was a night shift nurse for a good bit of that. I kind of did all of the shifts, but on this particular time, I had been a night shift nurse and I was doing weekend days. I had a patient that I came in the morning. I was day shift this time. I came in the morning, and my patient was being extubated. She had come in with seizures after detoxing from alcohol. And she was being extubated and leaving against medical advice in the morning. And I was told on my shift change that this patient was coming in, leaving against medical advice. We were trying to extubate her safely and get her out of the hospital. As a nurse, you come in with, you hear that on shift report and you're like, wow, this is going to be a pretty tough day. Usually when you have patients that are leaving against medical advice, something's happened, the patient is upset, it's going to be a tough emotional day. But for some reason, I came into this day feeling really peppy and energetic in the morning, which I never do. I'm not a morning person, but I came in and just enjoyed this patient. We were, figuring out what she wanted to watch on TV that morning, while we were making sure that she was safe after we had taken her off the ventilator. We were making sure that she got breakfast before she was leaving. We were just having kind of a good time talking to each other. But all the same time, I was packing her up. I was getting her ready to go. I was starting to take report on who was downstairs in the ER that was going to need that bed, and making sure that we were kind of keeping her on her way out. This is a patient who had had multiple seizures over the past week and had gone into multiple ERs. And she had found her way into mine on this particular day. After I packed her up and she was, ready to go, she grabbed her things. We got her packed up. We made sure that we had a plan about, where she would be going next, all of the normal discharge that we usually do. And she left. And about 10 minutes later, after she was discharged, after I'd already turned over the room, after I'd already told the ER nurse and the bed management that the room was empty and ready for the next admission, she came back into the lobby area and she came looking for me. And she said, I really wish I hadn't left. I wasn't ready to leave. I was angry that I was put on a ventilator and I didn't want to leave. And now I feel like you've been treating me like a person and I want to stay and I shouldn't have left in the first place. And she said, can I come back? And I told her, let me go talk to the team, because I didn't know what to say. I knew she probably couldn't, but I didn't know what to say. And so I went back and I talked to the residents and I talked to our attending physician and I said, she wants to come back. She'd had all these seizures. She probably wasn't ready. They hadn't wanted to let her out, but she was leaving AMA. And the residents at the time who had been on overnight basically said, no, she needed to go. She wasn't compliant. She didn't want to stay. We weren't going to be able to help her anyway. And the attending physician looked at me and he said, Lauryn, what do you think? Should she come back or not? And I just sat there and I stared at him because I didn't know what to say, because I didn't know where my priorities needed to be. I had a patient down in the ER that was waiting for that bed. I had a patient who wasn't really safe to go back out on the street. She was probably going to have another seizure. And where should my priorities be? And I basically said to him, I can tell her to go back down to the ER and get triaged again. And so that's what I told her. I went back out and I said, I'm sorry, we've already given the bed away. You can go down into the ER and get triaged again. And I didn't see her again. And I will tell you that story haunts me because I know what happened to her. I don't truly know. I never saw her again, but I know what happened to her. And I know that if maybe we had just been able to sit and talk with her overnight, if maybe we had been able to have patience, if maybe we had not rushed her out, and by we, I mean me, if I had not rushed her out in the morning, maybe I could have turned her around and not had her leave AMA in the first place and not really be set up in a situation where I don't have anywhere to put her anymore. And I tell that story because every single day we are faced with these really challenging conversations about competing priorities, about the consequences of maybe not treating people the way that we should have. I knew she didn't want to leave by the time I was discharging her. I should have asked her again before I let her out the door. I knew she probably would have stayed if I had asked her again. And I didn't. And I should have. And there are those moments where you feel like you didn't do the right thing. And that's our entire system right now. We have a system where we have what's called moral injury. And I'm sure every single one of you who's been practicing has experienced moral injury. It's a soul wound. It's a place, it's the true definition here is that it's a psychological distress that occurs when one behaves or witnesses behavior that deeply violates held ethical commitments, like do no harm. But what I will say is I think most of the time it's not some major event. Most of the time when we as clinicians have moral injury, it's the small things that add up. It's the meh job that you did when you were discharging a patient. It's the patient education that you provided just by handing a whole bunch of printouts to the patient. It's the, realizing that you're asking your patient a screener that has really important questions on it, but you're probably asking it in a way to make sure that you get all negative responses because you don't know what to do if they say yes. You don't have the resources and you don't know where you're supposed to go. And I say that because those are the little things that I think as clinicians, we do regularly, even when we are trying to be the best nurse that we can. I was trying to be kind to that patient in the morning because I wanted to be a good nurse. I wanted to be there for her, but I still missed a step. I missed a step that I think still mattered. And we do that often, and we're doing the best we can in a system that maybe isn't set up for us to succeed. And then we have burnout. That leads us to regular, systematic burnout that we are seeing not just in Virginia, but across the country. This chart here that I'm showing you is from a pilot that my old organization, the Virginia Center for Health Innovation, did, where we were working with 5 different health systems across Virginia to look at retention and burnout issues among their clinicians. Now, UVA is not part of this, but what we saw is that Virginia looked pretty similar to the rest of the country. So I imagine that many of you have felt the same thing. When we have those small moral injuries that add up, we have a situation where we have burnout, where we have retention issues, and it just cycles because you have a clinician that leaves and then all the rest of the work goes to the clinicians that are still there, and then they get burned out, and et cetera, et cetera, et cetera. So what we see here is about half of all clinicians are burned out in Virginia, or at least are reporting some level of burnout. And where does this leave our patients? I mean, I think it's clear that my patient probably had some negative consequences. It's quite possible she made her way into another ER, and she found help at another hospital, and I hope that she did. I will tell you that my own experience as a patient has also been pretty uneven. I actually went into nursing originally because I had a traumatic brain injury when I was in high school. And I had multiple situations where I was hospitalized due to drug interactions, where I'd have one provider that was giving me one to treat one symptom, and another provider giving me something else to treat another symptom. And I went into the ER a couple of times. I also had a lot of sequelae that came after that brain injury that I was hospitalized for. And I went into nursing because my care coordination was so dysfunctional. And when I was staying in the hospital, it really mattered who my nurse was and what that day looked like on whether or not that stay was completely miserable or tolerable. And so for me, when I was out of college and decided what I wanted to do with my life, I was originally working in DC, And I was actually working as a hospital lobbyist with the hospital association, and really decided I didn't know what it felt like to be that nurse. I didn't know what made one nurse better than another, or one stay better than another, or how I could really help the system be better without having that on the ground experience as a nurse. And so that was why I went back to nursing school. Because we do have a situation where we have a tendency, if we don't understand something, to just dismiss it, or if it's not within our scope, to just send people elsewhere without really helping to coordinate. We don't have a system that's truly coordinated across our care, and that leads to a lot of challenges for our patients. So that brings me to our Band-Aids. And let me just say out loud that heroism is not a workforce strategy. We have truly heroic people that do this work every day, but that is not a workforce strategy. Martyrdom is not patient safety. We focus on resilience and making sure that the people who work in this system are resilient. We need that. That is true. That is reality today, but that is not a sustainable strategy. We talk about the heroes in healthcare, and I think when we have various crises like the COVID crises, it's completely appropriate to be calling people who are going into work every single day heroes. That's not a workforce strategy. We need a system that does not require heroes to go to work. Patient safety should be the bare minimum, and yet we spend so much time focusing on patient safety because it's a real problem. But we need to be able to have a system where patient safety can be the default, and it's not right now. And that's why we talk about things like staffing ratios, because we have to be able to support that. But those are Band-Aids on a system that fundamentally isn't working for us. And so it is understandable that right now we take a lot of pride in making it work. And I do that, I think, especially in nursing. We can fix whatever the problem is. We can put the Band-Aid on it. We can have the immediate solution and make it work. And we have to do that every single day. And I'm not saying that when you go into work tomorrow that you're not going to have to do that. But putting together a system that actually doesn't look like that is really kind of where the goal is. And when we talk about where the problems are, they're becoming more and more acute. So Virginia has 3 of the wealthiest counties in the entire country. And yet, on average, Virginia's life expectancy is now worse than the nation for the first time. And it's actually decreasing while national average life expectancy is increasing. So we're going in the wrong direction, specifically in Virginia, and that's new for us. Quality of life is incredibly uneven across the Commonwealth. If you look at quality of life in the South Side and the Southwest region, we see a lot of problematic areas. And I think that even if we looked at this at like a zip code level, you'd see even more variation. So here in Virginia, we actually have an especially problematic situation. Sorry about that. So what would a system that cares actually look like? So taking from the 5 rights that I think we often talk about, and I know the number of rights often changes, but the generic 5 rights that we talk about, at least on the nursing side, looking at that on what the systematic side would be. The right care at the right time, by the right clinician, and at the right cost. And every single one of these is loaded. There are a lot of things that go into these. Just looking at cost for a minute, because this is the one that on the policy side, we spend a lot of time thinking about. The right cost to who? When a patient pays more, as clinicians, that is part of the money that goes into your salaries. So your salaries increase when the patients pay more. So we're always kind of having this conversation of, primary care providers, aren't paid enough. Yes. Also, you increase those salaries by having patients pay more. And so part of this is really trying to understand what the different dynamics are, how they work together, and how to get to the best possible solution and competing priorities that are very real. And we work in a system right now where every industry can villainize the next. But the reality is there are no angels in healthcare. We try to be every day, but there are no angels in healthcare. We are human beings that are all trying to do the best that we can. And when we look at policy, we need to be looking at it as a state of reality. We want to be able to assume the best intention while also understanding that sometimes humans are humans and there can be human failure, and systems need to be set up to address that. So zooming out a little bit, what does a policy lens on this look like? So there are a number of different places where policy can fit in. And to be clear, policy cannot single-handedly fix any of these issues, but these are kind of the levers that policy has. So you have quality measures. So policy can set different types of priority policy measures. Unintended consequences of that: increased documentation, increased educational materials. There are all sorts of things that come after when a policy gets set on a quality measure. There are payment models, and we'll talk about some that I think work in a little bit. Scholarships, loan repayment, what services are covered and by who, how much does it reimburse, who gets covered, how much does it cost to cover them? And we try to manage affordability, but as I mentioned, that's a really, really tricky one. And then just to give you an example of what this actually looks like in practice, these are the levers that policy can use for physician payments specifically. This equation right here on the screen is the Medicare fee-for-service payment calculation. So you have, just in one insurance type, these very complicated ways that a physician can get paid. You can either increase the work, the way that you calculate how much work goes into a specific service, the practice expense associated with a certain service, the malpractice risk associated with a certain service, and then there's like a conversion factor, and there are things that go into that, and then that's how you get your physician payment. So just looking at one piece alone, at physician payments, there are many different levers. And nurses, your entire salary is wrapped up in that practice expense. You are with the lights and the electric bill and the cost for the actual location, the rent, up in practice expense. So depending on how we think about our policies here, we have a lot of levers for things like physician payment and not a lot of levers for some of the other critical pieces of policy because they're all wrapped up into one single bucket. That said, I think there's still a lot of really important roles that policy can play in trying to build this system. And I know policy is typically very boring for people on the clinician side. I think it was the least attended class that I had in nursing school. I loved it, but I realized that it's not everybody's cup of tea. But there are a lot of places where you don't have to work in government to be able to address policy. And that's what I really want to leave you all with as we kind of finish up here. But there are so many different areas. This is just an example of how we worked with the Virginia Task Force on Primary Care to address different primary care systemic challenges. You can look at defining the priority areas, what it actually looks like, coming to a consensus on the actual baseline, all the way up through actually building interventions and an accountability structure. And I want to give one very specific example of a program that I was really proud of when I was over at the Virginia Center for Health Innovation. So one way that policy can address some of these systemic challenges is through a variety of different payment routes. And so I just showed you kind of that broad calculation. Well, how do we get around that? How do we start looking at our systemic without trying to break things up into all these little buckets? And how do we try to build something that's a little bit more holistic? Well, one pilot that we started doing was called the Primary Pathways Pilot. And this pilot is geared towards pediatric practices that are primary care, but wanting to offer behavioral health services for their patients. This has been a real issue where primary care providers are really overwhelmed by the volume and severity of behavioral health that they're seeing. And how do we help support them care for those patients? So we set up a pilot where we have 3 different buckets. We have practices that have really never done this kind of work, are little mom and pop shops, probably don't have a lot of data infrastructure. And then we have a tier where they're a little bit above that. They've gotten some data infrastructure set up, but they don't have a care coordinator, and they really need to start having a little bit more directive and supports to support a care coordination. And then the third one is saying, okay, now these practices actually have a behavioral health provider in-house. But how do we take all 3 of those tiers to help drive them towards the same outcome, where they may not all be at the same level of care themselves? They may not be providing in-house, but they are helping that patient receive the care that they need to. And so we did that through a couple of different ways, where we worked with health plans to help give upfront dollars and then predictable monthly dollars. And I will say UVA is actually a participant of this pilot, and it's been wonderful working with them, one of their primary care practices. And what we have found is now every single one of those practices has been able to turn around and say to me, I now know when my patient is going into the ER for a behavioral health issue and why it happened and who followed up with them. And I can call people, and I never was able to see that before. And while there are some practices who had been advanced and had all this data infrastructure, like some of the UVA practices before, a lot of our patients were not going to those practices. A lot of our clinicians were not working in those practices. And being able to see visibility, being able to have predictable payments that you know are coming every month, so that you're not spending, a lot of money on, frankly, salary increases or a fax machine, that you can actually plan predictably on things where I actually need to support this type of person, or I need to hire this type of person. But we have to be able to add predictability in payment, and sometimes upfront infrastructure dollars to be able to have some of that ability to plan forward and fix some of the issues that we had. And so that was this Primary Pathways pilot that has been really successful, and so far has about 16,000 children enrolled, as well as 34 practices. And this is an old version of this slide, but in terms of where you all fit in, I think the big piece here that I want to stress is you do not have to be in government to be part of rebuilding the system. The system gets rebuilt from every single level. The system gets rebuilt when clinicians stop just being able to focus on the Band-Aids, which they need to do because there are crises, but also can lift their heads up and start to look at some of the sustainability as well. That needs to happen at every single level. It needs to happen on the ground level, and it needs to happen all the way up to the government level. And that's because we need to be able to have people who can help define the problem. And defining the problem often starts on the ground, because there are different problems on the ground than there are when I'm looking at, trying to make the insurance companies all align. Those are different problems, but they all have different consequences that we need to be able to name at every single level. And then there's designing and implementing that strategy that all of you on the ground can be doing. And part of that is being open and willing to try new things. And sometimes that means new technology, heaven forbid, that I know is really challenging. And sometimes that means trying to make space in a really busy day to find long-term solutions and new workflows, as opposed to just the same workflow. Workflows make a huge difference in terms of trying to address some of these fractures. And then there's always looking at trying to be in leadership roles, whether that be on boards or committees or leadership in your institutions. And then there's public policy. At every single level, there's a role. And what I will say is, I think on the public policy side, physicians, you tend to do a better job of joining the conversation. Nurses, we don't have as many nurses. When I first started in public policy, I was told, you're a nurse, you can't do health economics. You don't know anything about economics. I went back and I got a whole PhD in it so that I could be in the room. It doesn't need to be that way. We need to be able to have discussions at every single level with every single perspective being at the table, because every single perspective is being able to identify a different fracture and a different challenge that we need to address. It doesn't just need to be about, nursing scope of practice. Nurses, you are a very trusted workforce. We need your view along with the physicians at every single point in this conversation. And I think this is really kind of where we get to building the models that care. We really need to be able to put together all of those different perspectives so that we have the patient at the center, that we have the clinician at the center, and that we have communities at the center, because it has to work for all three of those levels for it to actually be a functioning system. And while we are incredible in a crisis, we need to be able to build systems, and we deserve systems that don't require us to function in crisis mode to work. And so I know it's easy sometimes to be cynical and be busy, and I am in that place many times myself, but I hope that at least for this hour, we can all kind of lift up our heads, look at the system as a whole, and think about maybe how we can really start building a system that works better together. And with that, I see Margaret also popping up her head, so it's time for questions here. Thank you for your patience with my technical difficulties.
Thank you so much for that talk. I feel like really timely, and as a primary care doctor, really resonated. And I'll start off the questions, and then everyone else in the audience, feel free to use that Q&A feature, and I will convey your questions to Dr. Walker. My question, you alluded to this some, is something I've thought about a bunch, is there's this challenge that health policy can easily be boring. There's just so much details, there's so much minutiae, things like deductibles, networks, staffing rate, all of this just gets easy to get in the weeds. But I think as you recognize, as we all recognize, it's actually just matters of justice and values. And so I wonder how you're thinking about talking about policy to engage broad audiences. I think you've done some of this here, but maybe expanding upon that to not get lost in those weeds and sort of bring everyone back to the way we design these health systems sort of reflects how we care about people, and it's not just about these details. And I think, I'm wondering if you can sort of expand upon that.
No, I appreciate that question, because I do think policy tends to be really boring for clinicians. And it is, a lot of it is about money. And the whole point that people go into, care is because they don't want to have to deal with the money side. They don't want to go to business school. They want to deal with the patient in front of them and care. And I think one of the things that I would say is that your ability to care is based on the environment that you are in. And if you don't have a say about what that environment looks like, then you are cutting out your ability to care. And I will just give a very quick example of this, because I think part of connecting with clinicians is being able to give the exact situations where this might come up. So as part of the Affordable Care Act, there was a change where we started trying to pay more for outcomes. The goal was to say, we're not just paying on volumes that you're doing a lot of extra work. We actually want to pay on the quality of the care that you provide. That's easier said than done. And I think there have been a lot of unintended consequences from that. And one example of an unintended consequences is we started looking at things like central line infections. That started to become one of these events that we all started paying attention to because you started getting less money for them. So when I was a nurse and I was our patient safety lead on the unit, I used to look at all of these central line infections, and we would spend hours looking through them, not just how to actually fix central line infections, but we would look at how do we look at this and figure out anything that it could be other than a central line infection. And that's what actually happens on the floors. And that's part of this. And so if we don't start having the conversations up at the top to say, okay, you're looking at central line infections, but this is how that actually works in practice, is that we're just kind of spending a lot of time trying to roll things out, not necessarily trying to fix it. Maybe we're spending time trying to fix it too, but it's kind of a mishmash there. If we don't start having those conversations at the policy side, then you're just constantly dealing with the unintended consequences and starting to deal with more documentation and starting to deal with all of the patient education, and the papers you hand out start looking like this. And so that is why we need people engaged on the policy side, is because the policymakers don't always see that part of it.
Yeah, I think that's so true. I have a question from the audience. It's a detailed one. Someone is interested in the rise of state-directed payments from CMS for state Medicaid. How do you think about those payments and what they can be used for? And maybe you can, for those of people who aren't familiar, give a little broad overview of that as well.
Yeah, so state-directed payments are essentially when you have a program that is managed care, so in Virginia, our Medicaid program is a managed care program, meaning that we have private health plans that run the program. And a state-directed payment means that as the state, I can tell those health plans, here's some money that I want you to use for this purpose. Generally speaking, in Virginia, they have been used for hospital reimbursement. They can be used for other things, but nationally, that tends to be where they tend to be used, and it is in Virginia where they tend to be used. Those payments have been kind of twofold, usually, of how they've been used. One, they've been used because traditionally Medicaid reimbursement is really low. It's been hard to get providers in network. It's been hard to make sure that the costs of care are covered. And so that kind of tends to be where the state-directed payments, like why those exist. The other piece of why they exist is because as the state goes more towards managed care, and this is about 75% nationally of the country's managed care. In Virginia, we're 98% managed care. So it's a very heavily managed care state, meaning the health plans have a lot of control over what happens. State-directed payments are a way that the state can have some control over how those dollars are spent directly. So they can say, you have to do it, and to get this money, you have to do X, Y, or Z. And so that's part of what the state-directed payments are used for. They are part of the OBB, however you want to call it, OB3, HR1, it has a whole bunch of names. The One Big Beautiful Bill Act is reducing those. And so that is something that, we're going to have to be looking at in the future of what are going to be the consequences of those dollars being reduced. Are they critical? And if so, what are they being used for? And what do we need to do to look at kind of making sure that the Medicaid program really stays sustainable?
I have a follow-up question for that, which is about more generally about the managed care sort of majority dominance in Virginia, and how that came to be, and why was that intentional, and are there advantages to that? As a provider, I struggle in that there's not just one Medicaid plan that you sort of learn what drugs they cover, but there's like almost infinite, and so that creates a lot of extra work on the clinic side often.
That is a great question, and I actually had the experience of moving over into North Carolina, working in their Medicaid program. They were one of the last states to move to managed care, and I actually moved over there kind of helping them move to managed care once their state legislator had required them to. So I have a lot of firsthand experience with the challenges of physicians and providers trying to figure out how to now bill for 6 people instead of 1. A lot of the goal of managed care is, one, because when you are a state-run program, to increase provider rates, you have to get General Assembly approval. To do any type of VBP program, you often have to get General Assembly approval. And so by moving into managed care, you can be a little bit more flexible because they have that ability to do that without having to have every single kind of request go straight to the General Assembly. So that's part of it. Originally, what made most states go to it was actually a budget predictability. So as drugs started to be more expensive, as care started to be more expensive, the state budgets were rising. And so nationally, states started moving towards managed care because they could say, I'm going to pay you this exact rate for this person, no matter how much care that person has. And it gave the state some predictability in its own budgeting purposes. And that's really kind of where that originated in Medicaid. The success of that has been, I think there was a $3.2 billion Medicaid shortfall in this past year. And so, I think there have been some challenges with that. But a big part of it really is trying to do some of the flexibility so that rates can go up without having to have everything approved by the General Assembly. That said, it does mean that providers then have to have 4 different contracts with different plans to be able to care for all of the different Medicaid plans. So there are a lot of challenges associated with it, and the state has a little bit less direct ability to make some of those internal decisions.
Another question from an undergraduate student at UVA who's from South Carolina, who says, I'm interested in rural healthcare and coming up with strategies to get rural populations better care, especially diabetes care. What are some ways you'd recommend on how to get involved with advocating for policy or systemic changes in healthcare?
Yeah, the advocacy part, I think, is always a question. I think there's oftentimes there are these like advocacy days with the different associations, and those can be of varying benefit. What I would say is if there are specific issues, one, raising them up through the association so they know what issues they should be specifically talking about, not necessarily having you go up on Hill Day, which, by all means, that's also a great thing. But two, keeping an eye out for some of the, KFF is a great resource of looking at what's going on in policy where you could kind of insert yourself. So, for instance, on the rural health side, Virginia was just awarded a $189.5 million grant on rural health. So there are going to be opportunities on the rural health side to be getting involved. And I think making sure that you are connecting with the associations that might be able to have a voice at that table, making sure that those ideas are getting heard. And then they're always like, you have your legislators, you are their constituent, being able to be involved, whether it's calling your Medicaid agency, whether it's calling your state legislature, whether it's calling your association. There are different avenues to do that, but just staying aware of what's happening in the news will give you a really big leg up to tell you which for each individual issue, who to go to.
That's great advice. Another more detailed question from an audience member asking, do you anticipate some level of state-level solution to the elimination of Medicaid expansion as expected due to the trigger law? And what will the impact of this be in Virginia?
Yeah, that's a great question. And again, just to disclose, I'm not here speaking on behalf of the administration at all. Everything is my own views. What I will say is that the way that, I think there was a lot of concern that the trigger law, which for those of you who aren't aware, basically the way Virginia wrote its Medicaid expansion law says that if the federal government decreases the amount of federal match that it gives for Medicaid expansion, that Virginia has to end its expansion program. That's kind of the way that Virginia wrote that law. There are some caveats to that, some nuances, but that's kind of generally speaking how it's set up. And a lot of states did it that way. I think there were 14. Because there were 14 states, when there has been discussion at the national level about reducing that FMAP, there's been a lot of pushback because a lot of those states were the purple states that had that trigger law in there. I have not seen it in the General Assembly this session be revisited, but it was very much discussed last session. My assumption would be that if there was, again, kind of a discussion nationally about reducing that rate, that we would see that pop back up as a special session or a General Assembly session.
I know we're getting near the end of time, but maybe a final question is, in your role as an individual, but I know you have a new position in administration as well. What are your hopes for 2026 and, this next few years in terms of health policy and what you think Virginia might be able to achieve?
I really think that there's a lot of opportunity, and I level setting that there's also a huge number of challenges. I think I talked through the fractured system part during the talk, but we're also walking into a time when a lot of money is being removed from the system over the next few years and a lot of coverage loss. We're going to see a lot of people lose health insurance. And so we do need to be honest about the environment that we're walking into, but there are still so many opportunities for us now to have to think creatively, where we are put in a position where things are going to be tight and hard, where we have to think creatively to try to talk to each other across the different sectors. We're going to have this rural health grant that I mentioned, where there's a lot of opportunity there to really be investing in our underserved communities, and how to make sure that we're not duplicating things where we don't need to. How do we make sure that we're leveraging and maximizing where we can? And that's going to require physicians in different specialties working together, nurses working together. We're working across, clinics to hospitals to health plans. It's going to require everybody coming to the table and really with an honest framework of where our care may not be best, honest with ourselves and honest with where the problems really are, and being able to put aside some of the kind of 30-year-old disagreements that we've had to try to come to the table and really make sure that we, are taking this opportunity to fix the system.
Well, thanks so much. We're happy we have you leading us. Well, thank you to Dr. Walker. Thank you for everyone for attending our Medical Center Hour and Bice Memorial Lecture. I'm really glad we can all make this happen on Zoom. I hope you can join us in about 2 weeks. On February 13th, we'll be having our next Medical Center Hour, just in conjunction with Medical Grand Round. I'll be hosting Ray Williams, the Director of Education and Academic Affairs at the Blanton Museum of Art in Austin, Texas. We'll be talking about medical education in the museum. Thanks so much for coming, everyone. Thank you, Dr. Walker.
Yeah.